So we heard earlier about underdiagnosis and underrecognition, and I'm going to talk today a little bit about screening for borderline personality disorder. Is there a need to screen? Well, is BPD underdiagnosed? We published a study more than 15 years ago in which we compared clinicians' diagnoses to diagnoses based on semi-structured diagnostic interviews and found well, first we studied 500 patients who were evaluated with an unstructured diagnostic interview, over 400 who were interviewed with the SIDP, and found that many times more diagnoses were made, and this is in an outpatient sample, many times more diagnoses were made when a semi-structured diagnostic interview was administered. In fact, clinicians, in the absence of input of information from a semi-structured diagnostic interview at their initial evaluation rarely made a diagnosis of borderline personality disorder, 0.4% of the time. When the information from the SIDP was given to the clinicians, then many would make the diagnosis. So it wasn't simply a reluctance to make a diagnosis at that initial interview, but more a matter of within a 1-hour time frame, not collecting sufficient information to make the diagnosis. This was the first study. Other studies have likewise been done looking at the prevalence of BPD based on clinical and structured interviews, a study of 159 community mental health center patients. According to a structured interview, twice as many patients were diagnosed with borderline personality disorder compared to an unstructured clinical interview. In another well, this actually wasn't reported as a study. This was more in the context of just a description about personality disorder assessment in a college mental health clinic. According to a structured interview, 20% of individuals were diagnosed with borderline personality disorder when results were based on a clinical interview before supervisory input. 1.6% were diagnosed with BPD. After a supervisor lent their judgment, then that rate went up, but nonetheless, the overall results again show much less frequent diagnoses of borderline personality disorder in routine clinical practice based on unstructured diagnostic evaluations. So screening. There are some screening measures out there, self-report screening scales for borderline personality disorder. Quite frankly, there are self-report screening scales for probably the majority of the diagnoses in the DSM. And we're not about to hand our patients 50 scales to complete. So as a result, very few screening scales are used in routine clinical practice. So we approach the screening issue from a different perspective, and that is from a psychiatric review of systems perspective. So when someone comes in and presents for treatment, you elicit information about their chief complaint. You determine diagnoses often, or diagnosis related to their chief complaint, and collect, of course, other information related to psychosocial information, family history, developmental history, and so forth. But after making a principal diagnosis, the routine clinical practice is to inquire about, or hopefully the routine clinical practice, is to inquire about comorbidities. And that will often be done in a psychiatric review of systems by asking about screening or gate questions. So we wondered if it's possible to determine whether or not one or two BPD criteria could function as a screening criterion. Now, BPD, unlike many Axis I disorders and similar to all the Axis II disorders, recognizing, of course, that there is no more distinction between Axis I and Axis II. But all the personality disorders are defined polythetically. So there is no gate criterion. There's no necessary feature to diagnose any personality disorder. So our goal was to examine the diagnostic efficiency of the different BPD criteria and determine whether any could function as such a gate criterion. To function as such, we would want such a criterion to have high sensitivity. So when you screen for a disorder, the principal diagnostic efficiency statistic that you're interested in is high sensitivity. You don't want to miss anybody. The purpose of screening is a two-stage procedure. You cast a wide net, and then for those who screen positive, you follow up with the more expensive, intensive evaluation. So do any of the BPD criteria have sufficiently high sensitivity so that it can be considered or used as a gate criterion? And hopefully, such a criterion would also have high negative predictive value. That is, if the person screens negative, you don't have to worry about assessing any further. They don't have the disorder. It rules out the disorder. So these are the 9 BPD criteria, which I assume you're all familiar with. I just gave a portion of this. This lecture was a portion of another lecture I recently gave, and the audience would not have been able to elicit all of the BPD criteria. There's data in the literature as to how poor clinicians do at listing all of the criteria for major depressive disorder. Multiple studies have demonstrated that. So if the criteria for major depressive disorder cannot be recalled perfectly or near perfectly, you can imagine what the performance would be with respect to the BPD criteria. So we examined from our nearly 20-year study the psychometric performance of the BPD criteria in over 3,500 outpatients presenting for treatment. Almost 2/3 female, mean age of about 40, the vast majority Caucasian. All were administered the borderline personality disorder section of the SIDP. And what we found, we split the sample in half. This study's been going on for about 20 years. So we split the sample in half according to their ID numbers, odd ID number, even ID number. We also split the sample in thirds because over the years we've had 35 diagnostic interviewers, and we wondered if any one criterion would perform well throughout the course of the project using different interviewers. And we found that in splitting the sample in half, a criterion did equally well in both halves, with a sensitivity of over 90% in both, and a negative predictive value of 99%. That was true looking at the temporal thirds. And for the overall sample of 3,674 patients, the sensitivity of the criterion was nearly 93%, and its negative predictive value was 99%. So coming back to the list of criteria, I'd like to ask you, and I'd like to do a survey. What do you think is the criterion that would function this well, that would have a sensitivity above 93% or about 93%, the highest sensitivity of the BPD criteria, and a negative predictive value of 99%. And then I'm going to show you a list of other studies that actually support our findings. So by a show of hands, which do you think that the avoidance of abandonment should be the gate criterion? Unstable relationships, identity disturbance, impulsivity, suicidality, self-injury, affective instability. That seems to have the largest number of people. Emptiness, anger, stress-induced paranoia, dissociation. So there's actually less heterogeneity here. There does seem to be not a consensus, but more individuals voting for affective instability. In a general psychiatric audience, no consensus whatsoever. Each criterion had about an equal number of votes. It is affective instability. affective instability had a nearly 93% sensitivity and 99% negative predictive value. And this is consistent with multiple other studies that have been done looking at the diagnostic efficiency statistics of the BPD criteria. And I do not list, and of note, I'll just note one study in particular, and that's the CLIP study, in which there was a 94% sensitivity. And what was most interesting about the CLIP study, and again, all of these studies found that affective instability was the criterion with the greatest sensitivity. In the CLIP study, it not only had a 94% sensitivity cross-sectionally, but they also did another report where they looked at prediction of BPD diagnosis 2 years later, and it had a 90% sensitivity for that as well. So this paper was sent out, and I'm just going to briefly go over the reviews. I always like looking at the reviews of some of the papers that I sent out, because I was kind of impressed with a sample size of over 3,500 individuals. What were the reviews of the paper? And I'm going to briefly read some of them. This paper is well thought out, nicely written, well analyzed, and presents findings of real clinical significance. Perhaps some of the reviewers are even in the audience. The idea of a gateway criteria for DSM diagnoses are very useful, etc. I have 2 suggestions. Mention that Linehan was the first person to recognize emotional dysregulation, and then talk about how misdiagnosing BPD could lead to inappropriate treatment. Before going to that, there were 3 other reviews. 2 were very positive, similar to this one. One raised the question of, do you really want to have a screen for a particular personality disorder, or are you more interested in a general screen for personality disorders, which is an interesting question that, if there's time, I'll talk about. So this was the letter I got back. I much appreciate having allowed us to see your paper. I regret that it's not possible to accept it. Next paragraph. I think most in our field would agree that a screening test for BPD is not clinically useful. And it was rejected from the American Journal of Psychiatry. And it's about to be in press in the British Journal of Psychiatry. But this was rather discouraging that the American Journal of Psychiatry does not believe that a screening test for BPD is clinically useful. So discussion. Screening versus case finding. I am not suggesting that borderline personality disorder can be diagnosed on the basis of the presence or absence of affective instability. I'm proposing it as a clinically useful screening criterion that, in the same way, if someone comes in for the treatment of major depressive disorder, and then you ask about you inquire about panic disorder by screening for panic attacks, you determine whether or not they may have generalized anxiety disorder by screening for persistent and pervasive worry, and so forth, that this criterion can be used to screen for borderline personality disorder. I think the question of screening for individual PDs versus any PD is an interesting one. I actually think it is more efficient to screen for individual personality disorders with one gate criterion for each personality disorder, if that's possible. And we're now analyzing our data set to see if, for other personality disorders, it is possible to identify a single criterion that will have a sensitivity above 90% and a very high negative predictive value. And the overall goal, and we haven't just done this with personality disorders, we've done this with other disorders as well, such as other polythetically defined disorders, such as attention deficit disorder, is can you develop an empirically based psychiatric review of systems? Thank you for your attention. Question? No, this was 3,674 individuals presenting for outpatient treatment, of whom 10% had borderline personality disorder.
So affective instability is the most sensitive for that broad population?
That is correct. Other questions?